Delighted to introduce my colleague, Rob Nix, who is a professor in human development and family studies in the School of Psychology and has an appointment that I think people in LNS will be familiar with, but Rob is also an extension faculty member. So that means that part of the teaching he does is working closely with extension educators and others throughout the state. And that means that Rob's work and understanding of the world is not limited to the ivory tower. We don't have any ivory towers here at UW, but the dilapidated brick tower. Having that kind of expertise to share with us, along with Rob's research. It's great. Rob has asked that we ask clarifying questions during the talk and we hold substantive questions till the end. And this clock is,
I think it is
now
accurate.
It's fast. Yes. It was slow before, now it's fast. Right. So it's, keeping us on our
1 minute fast.
All
Perfect.
right, I'll turn things over to you.
Great. Can you all hear me okay? If not, if the sound changes, just raise your hand. Also, if there are questions, I'm pretty flexible. I wasn't sure which one to recommend. Anyway, I'm going to be talking about improving the effectiveness of two-generation home visit programs for families living in poverty. My background is in clinical psychology, and I've always wanted to understand how the interventions that we have the effects that they do. And the primary goal of that work is to make the educational and social services for families living in poverty as good as possible, and doing that in the service of reducing these class-based disparities in child well-being. What I'm going to do today is talk about one of those preventive interventions that I've developed with my teammates. We're going to talk about the research informing that, the development of that intervention. I'll talk about the recent findings from our most recent clinical trial, and then I'll talk about our efforts to disseminate the program through extension and through the Wisconsin Department of Children and Families. These projects have a ton of collaborators. These are really big projects with lots of moving pieces. These are my collaborators here. Most of these people listed are former graduate students. And I also have lots of collaborators at Penn State. I also have a collaborator who was at West Virginia University. She's now at University of Florida. And then we've had lots and lots of community collaborators. All of these people are the directors, administrators, nutrition educators, clinical supervisors, and home visitors for early Head Start projects, programs across 7 different cities, rural areas, and small towns in Wisconsin and Pennsylvania. These projects also have lots of funders. Mostly we're grateful to NIH, which provided the bulk of the funding for what you're going to be hearing about today. So for those of you who don't know, home visit programs for families living in poverty are funded by the U.S. Department of Health and Human Services. They entail weekly meetings for families starting at pregnancy, usually going up to about age 2 or 3. Some programs go a little bit longer, up till the time the children actually transition to school. There are several different sanctioned programs that the government sponsors. All of these are evidence-based, or at least evidence-informed, which means that they're consistent with the research, even if they haven't been directly tested themselves. They all focus on the physical, cognitive, and social emotional development of children. And they do that through enhancing the sensitivity and responsivity of the parents. They also focus on like the caregiver life course. So helping caregivers get their GED, for example, if they don't have a high school education, or helping them address their own symptoms of depression if that's an issue. In general, about 50% of the parents who have been involved in our trials have clinically significant levels of depression. These home visits rely on this coaching model where the parents learn how to implement what the home visitor is teaching. And they're implemented by paraprofessionals. So a lot of the home visitors don't have a lot of training themselves. They don't get a lot of great professional development, and they don't work with great curricula. The curricula are good, but they could be better. And this creates some big challenges, I think, for this area of research. And it also created this opportunity for us to kind of step in and hopefully improve some of these factors. So these 2-generation programs, have been evaluated. In general, they improve the quality of the home environment. They improve parent engagement and play. They improve things like time spent reading. Yeah.
Is a paraprofessionals motivated by cost savings or a desire to be able to hire people who are sort of more like, in some sense, the people who are being served, or some third thing?
Yeah, so my guess is it's mostly for cost saving, but then rationalized. Like, oh, we'll hire people from the community. There are great advantages to hiring people from the community. A lot of people have been the recipients of home visits themselves and just love the program so much that they transition to that. It depends a lot on capacity too. So here in Madison, the organization Reach Dane that provides most home visits is able to recruit lots of people who have graduated from the School of Social Work or HDFS or other programs here on campus. And so most or all of their home visitors have a bachelor's degree in a related topic. If you go out into really rural areas of the state, those people are much harder to find, and it's really hard to fill these positions. And so I think in those cases, the organizations are hiring the people that they think are going to be best able to do this work. Does that make sense?
Yes. And so the treatment's going to be pretty heterogeneous spatially.
Exactly.
Results.
Exactly. Yeah. The interventions tend to reduce or increase time spent reading with children, and it also reduces the use of physical punishment. And so these are the effects that we see for parents or caregivers. We also see some nice effects for the children themselves in terms of cognitive development, language skills, sustained attention, and behavioral control. So when they've done these big trials, they tend to find pretty reliable effects, but all of those effects are pretty small. A lot of times people who are receiving these interventions only differ from those who don't get anything at all by about 1/8 of a standard deviation, or an effect size of 0.12. So it's a small effect size. The Early Head Start is the organization that we've worked the most with. So that's a downward extension of the preschool program. There are 2 versions of Early Head Start. One provides home visits for families. The other is center-based. We work with the home visit part of Early Head Start. And a few years ago, they were aware of the positive impact they were having on the families, but they wanted to do it better. In particular, one of the directors had been hearing a lot about the childhood obesity crisis in the United States and was watching what the families in her community were eating. A lot of times they were relying a lot on places like Quick Start for just a disproportionate amount of their groceries. And she wanted to kind of do better with in serving those families, but didn't really know how. So she approached some colleagues and me. I was at Penn State at this point with just this problem. How can we improve the quality of the diet that our families are feeding their children? I didn't know anything about childhood obesity at that point, but I had some colleagues at Penn State who knew a lot about that. I knew more about intervention design and analysis or evaluation. So we were good partners. So we came together, talked with these Early Head Start administrators, and realized there are interventions that have been tested to improve healthy eating habits, but none of them have been very effective. And our theory was that those interventions were trying to be efficient and see if we can just change this one target by being very, very focused. And sometimes that's a great strategy for intervention development. Sometimes it doesn't work. And so we knew that probably wasn't working in this case, and that we probably needed to be a little bit more expansive in the way that we thought about the intervention in order to kind of address some of those factors or root causes, kind of supporting the unhealthy eating habits. Yes.
If you're going to get to this, just tell me to wait. Can you say something about the theory of what we think leads to creates eating habits?
Wait, say that again. Can we get to the theory of?
Can you say something about like what's the theoretical model of what creates eating habits? Like what results in how people eat?
We'll be getting to some of that. How about, and if you haven't got a good answer within 10 minutes, 11.
So the timer now.
Raise your hand, because I do have lots of thoughts about that.
Great, thank you.
We talked to lots of home visitors about the barriers that they saw in the families that they were working with, about what impeded their ability to feed their children healthy diets. So one of the issues that was coming up is a lot of the moms that they were working with, or a lot of the dads, were pretty young themselves, and they had the diets of teenagers, right? And so they didn't really know how to introduce kids to fruits and vegetables because they weren't eating a lot of fruits and vegetables themselves. And then we talked to parents. We had 3 focus groups with parents enrolled in Early Head Start to talk to them about what they thought about these issues. And one of the things that we learned from the parents was that, you know, nobody objected to having their kids eat more fruits and vegetables. We were all on the same page about that, but that wasn't the parents' priority. They were saying things like, we enrolled in Early Head Start because we want our kids to do well in school and be well behaved, right? That's our priority. We don't mind doing a little bit around healthy eating habits, but we don't want that to become the focus. As a result of that community-based participatory collaboration, we created Recipe for Success, which was unlike anything that any of us had ever done. So in Recipe for Success, we target 4 factors that are most affected by poverty and most important to long-term health and well-being. The 4 factors or the way that we kind of identified what these 4 factors are, is healthy eating habits, toddler self-control, parent-sensitive scaffolding of learning, and parent-supported eating practices. And so I'll talk a little bit now about the different research lines that all contributed to the development of this project. So the first piece in this puzzle is around healthy eating habits. Like I said, there's this kind of growing childhood obesity epidemic in the United States. 1 out of 8 children who are ages 2 to 5 have obesity. The risks are higher among children living in poverty and among children living in rural areas. The health risks for childhood obesity are the same as they are for adult obesity. So in the United States now, we have children with high blood pressure, high cholesterol, kidney disease, and diabetes because of their diets. In general, diet-related issues account for about 20% of healthcare costs in the United States. One of the reasons that our healthcare costs are so much more expensive than healthcare costs in Europe, well, there are many reasons. Many of you could come up with lots of them, but one of them is that our rates of unhealthy weight gain are much higher here. There's this obesity paradox in the United States where we have children who are both malnourished and have overweight or obesity because they're eating a lot of calories, but those calories don't have the nutrients that they need to thrive. We also know that kind of fruit and vegetable intake during the toddler and preschool period is actually one of the best predictors of healthy eating habits in adulthood, right? That this period is when taste preferences are being formed. And one of the things that you have to do as a toddler is learn to tolerate kind of the bitterness and the sourness that characterizes a lot of vegetables, right? Like broccoli or Brussels sprouts. Children have adapted over generations to be wary of those things because as they start moving away from their parents don't want them eating any plant that they might find because most poisons tend to be bitter and sour. And so they're doing exactly what toddlers should be doing. And so parents have to kind of step in and teach them what is safe to eat versus not safe to eat. The second piece to this puzzle is around toddler self-control. So it turns out that self-control is that, ability to manage thoughts, feelings, and behaviors to achieve distal goals. And it turns out that taste preferences and deliberate self-control are both coming online around that same time, around age 2. And so this was an interesting convergence that made us think if we are if we're able to intervene on both fronts at the same time, we could change these long-term developmental trajectories, right? One of my colleagues in this study or in this work is Lori Francis, and she did a really, really interesting study a long time ago. Children age 3 into the lab, had them do all kinds of, little appropriate tasks. And then after, 30, 45 minutes, said, "You were so great. I have a present for you for all of your hard work today, but I didn't have a chance to wrap it before you got here. How about if you sit in this chair, we'll have you face the corner, I'll wrap your present, and as soon as I'm done, you can open it. But don't peek because I want it to be a surprise." Right? She had a camera focused on the children and just counted the number of peeks during that 2 minutes that it took the present. And what she found is if the kids had a lot of peaks, as indicated by the red line at age 3, they had a much higher trajectory of weight gain through the course of childhood, through age 12. If they had no peaks, as indicated by the green line, they had a much more normal trajectory of weight gain over that time. So, we all understand how kind of self-control and weight gain are related, right? If we've had a really hard, stressful day, it's just hard to refuse that, extra dessert at night or that, glass of wine. But it turns out that this connection starts really, really young. So kids are eating because they're stressed or because they're bored, because their parents are using food in order to soothe distress, or as just a fun activity, right? That a lot of parents living in poverty may not be able to kind of organize a trip to the Dells in the winter, but they can walk down the block and buy a candy bar for their child. The other piece of research that is really interesting in this regard around self-control is the work of Terry Moffat. So she and her colleagues did this study. It's a birth cohort study of all of the children born in 1 year in the city of Dunedin, which is in the South Island of New Zealand. And what they found is that if you look at children's self-control at, between ages like 3 and 11, and then adults functioning at age 32, what you see is this linear relation between kind of low self-control in childhood and low incomes as an adult. The other end of the relation, you see that kids who have a lot of good self-control during childhood tend to have higher incomes in adulthood. You see just the opposite relation in terms of the likelihood of being convicted of a crime. And you'll also see that opposite relation in terms of adults' health problems, including their substance use. Yeah. Oh, I'm sorry.
I was just wondering if that's controlling for their parents' income.
I don't know if it's controlling for parents. I mean, there are a ridiculous number of controls in these studies. So I don't know exactly what it's controlling, but they're this is a really comprehensive study, and they've included lots and lots of controls. So I would assume that that's the case. Is there another question? So the third piece of this is around parent-sensitive scaffolding, right? And that's a little bit different than just kind of sensitivity and responsiveness in general. So sensitive scaffolding is that ability to provide the exact right amount of support to promote children's success and their autonomy, right? It requires this nuanced understanding of what the developmental task is that the child's trying to accomplish. It requires the parent to know the child's own skills, and it requires them to monitor on a moment-to-moment basis how frustrated the child is, how engaged they are. So in this picture, for example, like if the child is succeeding at doing that puzzle by herself, the dad's just observing, giving her attention for that is perfect. It's the perfect amount of sensitive scaffolding, right? If she's just like randomly trying to put puzzle pieces together, right, he might need to up his game. they might say like, how about if we put all of the pieces with the straight edge together? And how about if we group them by color, right? And then that will help the child succeed. If she's still a little frustrated, the dad might, like surreptitiously move a piece so that it's within her sight line, right? Or if she still can't quite get it, he might put together a couple of pieces himself and kind of show excitement about that and help provide even more scaffolding, right? So this is a really complicated, hard skill if you don't know how to do it, but it's really important too. Sensitive scaffolding improves children's self-control, mostly because it allows them to sustain attention and persist at a challenging task for a really long time, right? We think, the model for kind of the development of self-control is that, the prefrontal cortex has some qualities of like a muscle, right? And you want to be able to use that muscle repeatedly for extended periods of time in order to develop that capacity, right? To sustain attention and continue to persist even in the face of challenges. We know that sensitive scaffolding can kind of mitigate that relation between poverty and child allostatic load, right? So like the work of like Shankov and others, they talk about how chronic stress can get under the skin of children, right? And the way that allostatic load can affect all of us is that if our bodies are stressed, then we crave different kinds of foods, right? If we're up at 3 a.m. working on, a paper or a big project, we're not like, inclined to go find carrot sticks, right? Or celery sticks. We're going to be, gravitating toward, cookies or potato chips or something else, right? And the allostatic load also changes the way that your body metabolizes calories. And so it stores them for fat because, because this response helps us prepare for stressful times in our environment, right? If we're under stress, it's going to be better if we have some extra weight because stress in our ancestors' times often came with lower amounts of calories in food. It's a little bit different in our current environment, which is part of the reason that we have this current crisis. The final piece of this puzzle is around supportive feeding practices. In order to kind of promote positive children's healthy eating habits, parents have to expose their kids to new foods 10 or 20 times. A lot of times when we're working with parents, they'll say like, oh yeah, my child doesn't like broccoli. We tried it once and they refused to eat it, right? They don't know about kind of that learning to tolerate that bitterness and how you have to expose 10 or 20. We know that like if women eat more vegetables while they're pregnant or while they're nursing, their kids are more likely to tolerate those bitter tastes, right? And so kids have to be exposed, but a lot of parents don't know this. We also know that kids are going to do better if the parents give them choices among healthy options. So even if you know that your kid always prefers slices to apple slices, just asking them, would you like some orange slices or apple slices with lunch today? It's going to make them more likely to eat the orange slices. We also know that parents need to model the enjoyment of the healthy food themselves. The other, what also works for children is to serve a fruit and vegetable free meal or snack. This can be a big burden for families, right? So what we talk to them about is the wonderful benefits of frozen food, right? So frozen foods are picked at peak ripeness and then flash frozen. That means that because they're picked at the peak ripeness, they have the maximum nutritional content that grades like it does when they ship, lettuce from California to Wisconsin in the winter. So in general, frozen foods are cheaper, they're more convenient, and they're healthier than anything that we can buy except what we could get at the farmer's market in the summer. We also know that kids are going to do better if they minimize distractions when eating. one of Sarah's and my colleagues. NHDFS has this wonderful study where she had undergraduates come in to a lab, and while they were in the waiting room, she said like, oh, we had a party earlier, there's some extra pizza in that box, help yourself. And they didn't realize that kind of the waiting room was the experiment, right? And if the TV was on while they were waiting, they ended up eating twice as much pizza as if the TV was off while they were waiting, right? So the same kinds of processes happen for children. We also talked to parents about eating with their kids at the table and providing only milk and water to drink. A 20-ounce, single serving size of Coke has about 14 teaspoons of sugar in it, right? If you look at the consumption of sodas in the United States over time, that trajectory is most perfectly on the increase in obesity over time. We're consuming a ridiculous number of calories, through just sodas and soft drinks. We know that fast foods tend to be high in calories, salt, sugar, and fat, but cooking at home leads to greater fruit and vegetable intake. Sarah, did that answer the question that you had about like the theory of like what informs children's eating?
You told us a lot about what's close to the child. I'm wondering if we know anything about like to introduce foods 10 or 20 times, you need to have just income to throw away broccoli 20 times before your kid eats it. Like those kinds of other factors. I don't know if that played into the model that you all had in mind as you were developing this.
Yeah, so one of the reasons that we talked to them about frozen foods, right, is you can take out a single piece of broccoli and defrost it, right, so that the parents who are living in poverty don't have to kind of go to the effort, going to the store, buying a whole head of broccoli, washing it, cooking it, and then putting it out for their child, and the child refuses it, and then they've got all of this broccoli that nobody else is going to eat. So I think that some of what we do is informed by those bigger contextual issues. There are ridiculous efforts, of these big companies to sabotage children's healthy eating in the United States. Right, there are some cereals that are designed for children that are 40% sugar, right, and those are the ones that are often at the bottom of the shelves, kind of put at eye level. There's lots and lots of horrible advertising that tends to be targeted toward children of color, children who live in poverty, to make them want to eat things that just aren't healthy for them and aren't serving their long-term well-being.
So, when you get to describing the intervention more, hearing about were parents getting nutrition label literacy or media, like how to talk to preschoolers around companies are trying to trick you, or and then are you working with them to make sure they had SNAP and WIC and things like that?
We do a little bit with the SNAP and the WIC, and I'll talk about that. We don't do a lot of that other stuff because those were the prior interventions that tended not to work very well. Parents like this food too. And it was really hard. Pardon me?
We all do.
Right. Visitors like the food, parents like the food, kids like the food. And it was really uncomfortable to have some of these discussions about how unhealthy things that we really loved are. And so we avoided all of that as it was just easier. And we could, maybe my colleagues who have specialized in this for many years could have those kinds of conversations with parents in a way that was sensitive and affirming. We weren't sure we could teach visitors to do that, especially if they weren't. And like I said, we knew that those interventions hadn't tended to be very productive. The United States, there's the whole SNAP Ed program. So the state gets SNAP money. They also have to provide nutritional education, and they do a lot of what we're talking about. And it hasn't been as effective as people had hoped. And so we took a different road. So this is the logic model of our intervention. We created Recipe for Success. The purpose of Recipe for Success was to enhance parent-sensitive scaffolding, which would promote the children's self-control and lead to healthier habits. But we also wanted to improve parent-supported feeding practices, which we also knew would lead to healthier eating habits. But remember, like I said, this wasn't the priority of parents, right? They wanted their children to do well in school and be well behaved. So what we talked to them about is the critical importance of this intervention in toddler self-control. The parents understood what self-control was, and they understood that if kids had good self-control, that they would be less likely to poke their neighbor in circle time, right? They would be able to sit still in kindergarten and learn, their letters or their numbers from their teacher, right? And so parents understood the critical value of self-control, but interestingly, they didn't have many strategies that they could identify that they were working on to promote self-control. So our intervention consisted of 12 food preparation lessons. They were embedded within home visits. The nice thing about these food preparation lessons were we weren't kind of sitting across from the parent telling them this is what you should do, but we could just introduce some of the points that I've been talking about as we cut open the bag of frozen broccoli. The other nice thing that we were able to do is teach parents how to use their WIC foods. Right? I was talking to a WIC administrator recently, and she said about 30% of WIC benefits are left on the cards because parents just have too much milk or they have too much peanut butter. They don't know what to do with a bag of dried lentils, right? And so our goal was to just use WIC ingredients so that parents understood better how they could take advantage of those benefits. And all of our recipes were very simple, required nothing more than a microwave. So this is kind of a colorful example of one of our recipes. It's a vegetable omelet. You can see at the bottom it includes 4 pieces of broccoli, a quarter cup of corn, 1 egg, and a slice of cheddar cheese. The thing that we really loved about using cooking for this intervention, or the focus of this intervention or medium, was that it provided so many opportunities for children to practice self-control skills. Right? If you look at this little girl, look how hard she's having to concentrate not to spill that milk. Right? We could all do this without even thinking, but she, it's a real challenge for her to sustain that attention, to exert that body control. Cooking also provides experiences in kind of persisting in a challenging task, taking turns, coordinating one's activities with somebody else, and waiting while something is in the microwave, for example, or if you also use a freezer sometimes. We know from Pamela Cole's work that children are going to be better when they need to exert self-control if they have distraction strategies, right? So one of our early Head Start collaborators came up with this waiting song, which children and parents can sing together while something's cooking in the microwave. Parents can also use this at a street light or while they're on the bus, wherever. It's just a really nice example of kind of giving parents strategies for things that they can do easily but just may not have thought of on their own. Children are going to be more likely to eat foods that they help prepare because they're invested in the process, right? In our lessons, kids are getting a lot of positive attention. Older brothers and sisters definitely want to be involved in the home visits in a way that they don't at any other time. If dads are around, they tend to be more involved in our lessons than regular home visits too. The other thing that we like about using food as the focus of our lessons is that the ingredients become more familiar through the cooking process, right? And so, a lot of learning to tolerate broccoli has to do with, getting used to it as something that's good or at least benign and not scary. And so if children take out, a piece of broccoli when it's frozen, and then they put it in the microwave, and then they, get it out of the microwave, and they use a paper towel to squeeze out a little bit of the moisture, and then they put it in the egg, and, then they cook it. By the time they're asked to eat it, or at least try it, it's less scary. The advantages of cooking with young kids too is that these lessons can be in the zone of proximal development for all children. Any of you who have worked with 2-year-olds knows that there's just a huge diversity of skills and interests. There's some things that are really hard to cook for a 2-year-old. There are other things that are really hard to cook for somebody my age, right? And so we really liked that. Children really love being involved in this grown-up activity. Barbara Rogath does this really nice research on how children in other cultures tend to be contributing to household routines at a much earlier age than they are here. And we also hoped that if kids became familiar with cooking, that they would ask to be involved in cooking when outside of the home visits, right? And so every time their mom went into the kitchen or their dad went into the kitchen to prepare a meal or a snack, that could be a booster for everything that they had been practicing in home visits. Parents have to cook anyway, so that was a really nice thing about using cooking. According to Forbes, 60% of millennials report enjoying cooking. Cooking and feeding is this primal form of nurturance, and so we're able to kind of tap into those like deep, feelings of parents. And we have long traditions of coming together around food. But cooking with a 2-year-old is hard, right? And we talk to parents about that. And so we tell them there are these 4 strategies that we know of from child behavior interaction, parent-child interaction therapy, that we know are going to make it more likely that your child's able to pay attention and persist in this challenging, these challenging tasks. These 4 behaviors are describing what the child is doing, reflecting what they say, giving them lots of praise for their effort, not just for who they are. Not good job, but, oh, I really like how careful you're being, and giving them lots of choices to enhance their sense of agency and their investment in the outcome. So, like if you were this dad and you were just describing, what the child's doing, you might say something like, oh, you're wiping the white part of the plate. Oh, and now you're wiping the yellow part of the plate. I can't see any food on that plate anymore. Now you're rinsing the plate, right? So the dad's not telling the child what to do. They're just paying attention and describing what the child is doing. And we show parents this picture of a Christmas tree that like a 3 or 4-year-old drew on their own. And then we ask this parent to now use your behavior description skills. And let's see what kind of Christmas tree your child can create with that extra support that you're providing, or when they know that you're paying close attention. And this is the same child, same day, but the quality of the Christmas tree is just so much better with something as simple as a behavior description, right? When we know that people are paying attention to us, we tend to bring out our A game. Our intervention, had kind of an outline of what to do, so stir ingredients together, but we also provided a sample script that home visitors could read before a lesson, so that they had an idea of how to kind of make that simple activity like stirring ingredients together really rich, right? So like have the child, choose, do they want to be a holder or a stirrer, right? Tell them that you'll do what, that they do it first, and then you'll do it for, next. That kind of thing doesn't tend to happen in home visits on their own. So we substituted about 20 to 40 minutes of a 90-minute home visit with our curriculum. And we met all of the Head Start performance standards. So the things that Head Start home visitors have to accomplish every month in a home visit, so that they didn't have to worry about doing anything else except for our lesson. We didn't add or extend the length of home visits, and the same home visitors delivered our lessons and regular lessons, right? So what we're testing here is kind of what happens when we change the content of a lesson, nothing else. We did an initial study with 73 early Head Start families in Pennsylvania, and we had positive outcomes in all target domains. And so we decided to do an enhanced efficacy study offered through Early Head Start in 7 cities, towns, and rural areas of both Wisconsin and Pennsylvania. The study had 242 families, and families were randomly assigned to intervention or usual practice within caseload, right? So if you were a home visitor, you had 6 families with 2-year-olds in your caseload, on average, 3 of them would get your regular lessons and 3 of them would get would get the Recipe for Success lessons. Yeah.
I'm sorry if I missed this. How often are the regular home visits and how often was the Recipe for Success inserted?
Yeah, so they were both weekly.
Okay.
Some home visit programs go to every other week by this point, but everything that we're doing here is weekly.
Did you do anything to be able to capture whether there was fidelity to regular practice if they were doing both of them? Like if people responded really positively to this, did they manage to not start doing it with the control cases?
Right. It's really hard to do these lessons with the control families because it involved kind of bringing food. It was really easy to, there were no instances. We had audio recordings, 2 to 3 home visits per family. And at the end of kind of rating those audio recordings, we guessed whether it was a Recipe for Success lesson or a regular Early Head Start home lesson, and we were correct in 100% of the cases.
Yeah, I wasn't thinking they would do like the whole intervention, but like some of the ideas from it, if you were not seeing the regular narration or things like that, could some of that way of scaffolding parents
So
engaging their kids seep in?
right, so that's the danger to us of doing this randomized design within case, right? If there is a lot of that, it's going to work against our ability to find an intervention effect, right? It's not going to increase the type 1 error, right? Or type 1 or type 2, one of those errors. It's going to make it less likely. And so, yeah, there probably was a little bit of that. Once parents learned once home visitors learned the waiting song, they were using that with a lot of families, according to kind of self-reports. So that there might have been some of that, but it didn't seem like there was as much as we had hoped, of just kind of that natural. Like, you know, my guess is when your child was 2 and would say something, it would have been hard for you not to kind of reflect what he said. You know, we hope that some of these skills become just overlearned, but it takes a while for some of that time. So in the efficacy study, we had pre and post intervention assessments. We also followed families up at 9 and 18 months after the assessment. Like I said, we recorded home visits so that we could assess fidelity to the model. We also had video recordings of parent-child interactions to assess what was actually happening. We analyzed our data with hierarchical linear models where families were nested within the home visit caseload, but intervention effect was at the family level, which increased our degrees of freedom and the statistical power of our study. We controlled for the baseline value of the outcome. We also controlled for all of these other factors like study site, family race, gender, marital status, education, and so forth. These were things that we had included in our grant application, and that some of the journal that we published in wanted us to maintain because that was our plan. But it turned out that there was no variance or certainly no statistically significant variance at the level 2 case home visitor caseload level, and none of these other covariates at the bottom were actually related to the outcomes. And so they weren't doing a whole lot. They weren't affecting the models much. We tried it both ways, with and without all of these controls, and got essentially the same results. So first, we wanted to kind of assess the intervention's effect on sensitive scaffolding. As I have been talking about, we did all of our lessons in the kitchen preparing these meals. And what we wanted to know is, had parents learned what we were teaching well enough that they generalized all of those skills, like the behavior descriptions or the reflections or the support for learning that's kind of sensitive scaffolding, in a completely different context. And so we had parents teach their kids how to use a bowling ball and bowling pins, right? Parents know how that game goes, but most 2-year-olds don't, right? We had them build a tower, kind of taking turns putting blocks on the tower. As you can see, these blocks are different sizes, and so that created some challenges. We also had them do the shape puzzle, where the parent could touch the ball, but they couldn't touch the yellow pieces. All of this was videoed in the home, and then we brought it back to Wisconsin and had a group of graduate students and undergraduates rate things like behavior descriptions, choices, praise for effort. And what we saw is that if parents had participated in Recipe for Success lessons, as indicated by this blue line, versus the regular early Head Start lessons, as indicated by the red line, they were much more likely to be engaging in those core parenting behaviors. So again, behavior descriptions, reflections, choices, and praise for effort. Likewise, if parents had participated in our lessons, they were showing a lot more learning support behaviors, like that scaffolding that we were talking about. These effects are like 0.3, 0.26, which means kind of almost a third of a standard deviation, or a quarter of a standard deviation. And so these are decent sized effects for a prevention trial. Next, we want to look at responsive food parenting. So, how do parents get their kids to eat something new and healthy? We had things like dried seaweed or prunes, right, which you can get in grocery stores, but most of our families hadn't really tried these things. And we were interested in seeing if we gave parents something new that they had never tried and that their kids had never tried, how did they how did they try to get their kid to see if they liked it, right? And so we said, here's a new snack, see if you and your child like it or not. And that was about it, right? And some of our parents would take that, if you haven't had dried seaweed, it has a really strong smell, and just a different texture than, most of the foods that we eat in the United States. Many of my graduate students grew up eating dried seaweed and love it, but most of our parents in rural Wisconsin and Pennsylvania hadn't tried it yet. And some of the parents were just very, very emotive in their perceptions of this, and would be like, you want me to feed this to my kid? And so not surprisingly, their kids wouldn't try it. Other parents would like take a little tiny bit, and then they might put it on their tongue like, interesting. What do you think, right? We want that kind of second response. That's going to be more likely to kind of encourage healthy eating habits, right? And what we saw is that very thing, that if a parent had gone through our lessons, they were much more likely to be responsive, non-coercive, and sensitive in the way that they presented these new foods to their kids. Next, we were interested in kind of differences in children's self-control, right? You all have probably heard about the marshmallow experiment. We had our own version for a 2-year-old, which was putting an M&M on a plate and saying, you can eat this, but just wait until time is up. For a 2-year-old, times were like 5 seconds, 15 seconds, 30 seconds, and 60 seconds, right? We also had Like I said, our home visitors go to the homes, and that's where all of these assessments were conducted. Our home visitors, or not our home visitors, our project interviewers didn't know whether a family had gotten Recipe for Success lessons or continued in regular Head Start. But at the end of their visit, they were asked to rate the children's behavior on things like attention and persistence with the tasks. And what we saw is that if kids had gone through our lessons, they were much more likely to pass our M&M test, and they were much more likely to be rated by these unknown interviewers as having good kind of task orientation and attention. We also had parents complete ratings of their children's compliance and things like the number of meltdowns that they had had in the previous week. And we saw that if families had gone through Recipe for Success lessons, the children were much more compliant and much less likely to have meltdowns. And you can imagine if you're a parent living in poverty with a 2-year-old, many of whom have depression, just having children who are more compliant and less dysregulated is going to be a huge shift in the quality of your life. Finally, we were interested in changes to healthy eating habits, right? And so remember, I said that one of the things that we were hoping would happen as a result of these lessons is that kids might become more involved in meal and snack preparation. The other thing that we did was looked at, we had parents complete these daily diaries of everything the child had eaten. And we asked, what did your child have for breakfast? What did they have for morning snack, lunch, afternoon snack, dinner? And was there anything else that they ate during the day? So what we saw is if families had gone through Recipe for Success, they were more likely to continue to incorporate their children in meal and snack preparation, and their kids were much more likely to have meals and snacks that included a source of protein and a fruit or a vegetable. We also, like I said, this whole project kind of started out focusing on obesity, but that wasn't really, like, we never talked to parents about obesity. We just talked to them about getting their kids to eat more healthy fruit and vegetables, but we did weigh the kids. And so we knew the percentage of kids who either had overweight or obesity at the beginning of the trial, and we looked to see what their weight was at the end of the 12 weeks. And what we saw is that there was actually a pretty big effect on kind of the change in weight among those children over the course of these 12 weeks. This is only marginally significant, so I think the p-value is like 0.7. But the effect size is much greater than anything else out there for children this age.
The effect size is 0.4 of a percentile. Am I reading the title right?
So it's 0.35, which would be, between it's about a third of a standard deviation difference between children in the intervention group and children in the control group. So this is a Cohen's d effect size, and it's just a way of creating kind of a standard metric for these outcomes that have lots of different metrics.
Standard deviations of percentiles?
Pardon me? It's not a percentile.
There's percentile up there. Maybe that's what's confusing me.
Oh, no, it's the BMI for age percentile. So we look at, if you're a child who's this tall and weighs this much, CDC has a chart where they tell you what percentile for BMI that child is. Mm-hmm. And then we took those percentile scores and averaged them across the intervention, across the control group, and computed the standard deviation of the percentile score to calculate the Cohen's d.
Okay.
Sorry about that.
There's several levels of indirection.
Yeah. Thank you for clarifying that. We also wanted to see, basically, as you can see, we were successful in virtually everything that we hoped to change. Over the years, I've had graduate students who were interested in other aspects. So I had one graduate student Yaron Park, who was interested in kind of how did parents apply what they were learning in supporting their children to their own lives, right? And so she included a couple of measures 18 months after parents ended the intervention, where she asked parents about problem solving, coping responses, right? And so parents are constantly faced with new child rearing challenges, right? And what she found is that parents who had gone through Recipe for Success were much more likely to kind of engage in active problem solving rather than just disengaging and hoping the problem would go away. What she also found is that parents reported that they had more self-control if they had participated in this, that what they had learned about supporting self-control in their children, they were actually applying to their own lives. I had another postdoc, Vivian Tamkin, and an undergraduate student, Alexis Matthews, who transcribed the whole parent-child interaction tasks for some work that they were doing. But because we had the transcripts, we could look at the bottom for the number of words that the parents and the children had uttered during those interactions when they were bowling or building the block tower, right? And what we saw there is if parents had gone through Recipe for Success, they were using something like 200 more words during our assessment than if they hadn't got through the intervention. And this is a really big effect size. And we know, there's so much research out there about the impoverished language environment among many children living in poverty. And so we're super excited to see that parents were kind of using these language skills, which are going to be so critical for children to learn how to read in other activities. We want to look at kind of therapeutic mechanisms. So how did we have kind of the effect on the intervention that we did, or on all of those outcomes that we did? One of my students, Sarah Broughton, used to work as an early Head Start home visitor between college and graduate school. And so she was really interested in what do we know about home visits from kind of the research perspective, right? We know that there needs to be a really good kind of parent home visitor working alliance. We know that kind of the content, the educational content of the lessons needs to be really high. We know that the home visitors need to be sensitive to the parents' needs. We know that the parents need to be really involved and that the children need to be really involved, right? And so she listened to, she and this team that she organized listened to over 500 of these audio recordings of home visits. I think we're the only data set in the nation that has such rich kind of insight into what actually happens in home visits. So Sarah and her team listened to over 500 recordings, made lots and lots of different ratings, and kind of was able to assess how home visitors fell on each of those dimensions of high quality home visit, right? And so some families, so in this graph, 0 is an average. So some families were high in working alliance, educational content, home visitor sensitivity, parent engagement, and toddler engagement, right? So across the board, this is the kind of home visits we all strive for. This is what Ed Ziegler and others, when they were first creating Head Start, were hoping children would receive. There are lots of families, though, that were getting home visits that were below average in all of these things on this graph. 0 is the average for the sample. And so, there's some variability among the dimensions, but they're still well below average on every single one of those. And then there was a third group of families. This is all latent profile analysis, so the groups are empirically derived. There were some families with a mixed profile, right? And what these home visits are is low working alliance, relatively low educational content, really high sensitivity, low parent engagement, but high toddler engagement. So remember I said that home visits are designed to be kind of a parent coaching model, right? These are not parent coaching. When you listen to these tapes, sometimes you could be like 45 minutes into the tape without even realizing that the parent was in the room, right? And these home visits, what had happened is the home visitor had just taken over and was kind of teaching the child what they thought was important, but not really teaching the parent to do what they were doing. So these are the 3 empirically derived kinds of home visits that we saw among those 500 audio recordings. So now what we want to see is there a difference between the prevalence rate of home visits and Recipe for Success versus the prevalence rate of as usual home visits, right? Remember, all families were randomly assigned to groups, so any difference in those prevalence rates would be an indicator of an intervention effect. And what we see is that in usual practice, 40% of families are getting those home visits that are high across the board. But in Recipe for Success, it's up to 82%. For the blue group, below average in all regards, 30% of usual practice versus 13% of Recipe for Success. And for that red group, where it's all kind of home visitor driven, 27% of usual practice, but only 5% of Recipe for Success. So we think it's probably this kind of dramatic change in the quality and the nature of the home visits that was accounting for all of our positive intervention effects. We then wanted to look at kind of sustained benefits. So it's nice to have kind of post-intervention differences, which is what I've been talking about to this point. But we also looked at what happened 9 months after and then 18 months after the end of lessons. Yeah.
Sorry, just to go back to that last slide. So is your conclusion from that the curriculum actually creates better home visitors?
Yes.
Or that the curriculum is skill proof? Like you could have a bad home visitor and take this off the shelf intervention and you can't screw it up.
You can't screw it up, unfortunately. But yeah, our goal is, the way I talk about it, is to make the intervention facilitator proof, right? So that even, I think we see this in a lot of teaching, or what, the work that they do in the School of Education, right? That good teachers are going to be able to deliver almost any curriculum well, right? What you really need to worry about are those teachers who are below average, right? And we see the same thing in our data, that there are some, 40% of home visitors in the control condition who are delivering great home visits, right? It's that other 60% that we're worried about. And what we see is that by giving them a more structured curriculum, where we've spent hours and hours kind of refining every lesson, right? You saw the list of all of the people who have thought about these lessons and have contributed to kind of the quality of the curriculum, right? What we're comparing that to is a lesson that a below average home visitor might be able to create between in the 30 minutes that they have between 2 families during the day, right? And so that's exactly what we're thinking is the value of this approach, that if we can, instead of it's much easier to create a good curriculum than create amazing, excellent home visitors, right? And that if we can really boost up the quality of the work of those home visitors who are struggling, who may be kind of burning out because they're ineffective, we're going to have a much bigger impact, especially if we don't see any degradation in the quality of the home visits that people at the top of the continuum are providing, and we never see that. Does that answer your question? So we want to look at sustained benefits. So what you see here is that, like in those core parenting skills, right, that intervention control group difference that was evident at post-intervention continues at 9 months and 18 months, right? The difference doesn't get bigger or smaller, like the behaviors increase just because the kids are getting so much older, but that intervention control group difference doesn't change. We see the exact same thing in terms of parent-sensitive scaffolding, parents' learning support, children's emotional and behavioral self-control, children's attention and persistence, and their compliance and cooperation. So then we wanted to look at kind of moderated effects. So what happens among those families that are at highest risk? Again, a different set of students, this is Christina Kemp and Yaron Park, looked at all of the different ways that we rated the videotapes of parent-child interactions and used latent profile analysis to identify 3 groups. And here, basically, they got a low, medium, and high group in terms of their demonstration or display use of those different behaviors. So we wanted to see first, well, what happened to those families from baseline to the end of the intervention, and then what happened from the end of the intervention to our follow-up period. And what you can see is that among these families in this trajectory or this profile, if you were in usual practice, you stayed at that level. But if you were in Recipe for Success, only 27% of the Recipe for Success families who were in this profile initially stayed in that profile. In contrast, the families who moved up from the low to the moderate trajectory or profile, only 15% of regular early Head Start families made that move, compared to 58% of our families. And then the last finding that I'll share is around telomere length, right? So we took a fancy Q-tip, rubbed it on the inside of children's cheeks. You can extract DNA that way, and then look at indicators of their chronic stress. And what we found for them is that if you were in Recipe for Success and you had a parent with clinically significant levels of depression, your stress, the chronic stress that you experienced was less, right? There was less degradation in child telomere length if you had a parent with depression and you were in the intervention group. And so this is one of the first studies where you can actually see that the effects of the intervention also got under the skin of these children. So if you compared to nothing at all, remember at the beginning I talked about how early Head Start produces significant intervention effects, but they're small. So they tend to be about early Head Start compared to nothing at all produces a change of about 1/8 of a standard deviation. In our study, what we found is that Recipe for Success compared to early Head Start produces an intervention effect of at least 1/4 of a standard deviation. It costs about $4,800 to deliver early Head Start home lessons on average. And on average, parents are enrolled for about 8 months. If you stay for the entire time that you're eligible, that cost goes up to $25,000. Our program costs an extra $300, right? So for kind of shifting the money around, less than 5% of the budget, you can more than double your effect sizes. Right now, we're working with the Wisconsin Department of Children and Families to make our program available to all home visit programs. There are 34 in the state of Wisconsin, so that our lessons are now the usual practice. So that's been super exciting. And we're now kind of in conversation with Parents as Teachers, which is the biggest organization that trains home visitors how to do their work, to disseminate this work even more broadly. This kind of community-based participatory research approach we think is really critical, focusing on kind of root causes, being well-grounded in research was really important, and embedding these new interventions within a current evidence-based practice is a really important opportunity to take advantage of current infrastructure, but make it more effective so that you can do even better to reduce these disparities that we see. Thank you.
I had a question about embedding this in different home visiting models, right? So like early Head Start, that's a very complex home visiting model versus Parents as Teachers. And I think has more evidence of success across a lot of different domains than parents as teachers, right? Which is so like in some ways embedding it in, I don't want to say the lesser, but like maybe, you know, a different model that is providing less, like that's going to make that model way better.
Yeah, well,
Right?
so you could see it working both ways,
Yeah. Or
right? So
they-
it's,
if it's skill proof, right? Because we said it's skill proof.
yeah. So, you know, so what we did was tested our model to the very best out there, right? Maybe we needed that kind of infrastructure that the very best out there supplies in order for our work to be successful. Part of this dissemination is Early Head Start's not the most popular home visit model in Wisconsin. Strengthening Families America, or Healthy Families America, HFA, tends to be the most popular one. All of our programs were Early Head Start programs, but I think all but one of them used the Parents as Teachers curriculum within the Early Head Start model. This has been the interesting thing about like these dissemination efforts, to see like, you know, the biggest challenge for us is that like Healthy Families America, by the time kids are 2 or 3, the home visits have moved to twice a month instead of weekly. And so it's just a little bit harder to gain that momentum from visit to visit than it was when we were doing it on a weekly basis.
I mean, it's, so I worked at the Department of Children and Families when McBee first came out. So I was very involved in this, but the response from communities and the Department of Health Services at the time was like, which model can we serve the most kids with?
Right.
Versus like, which one has shown the largest effect or.
Yeah.
So I think this is a really interesting opportunity.
Right. So the nice thing about kind of that dissemination work is that when we train home visitors in using our lessons, all the feedback we're getting from both them and their administrators is like the quality of home visits in general has increased, and they really like it. But yeah, it's a huge leap to kind of take what we've done in the context of a clinical trial, even one that was conducted in the community with home visitors as the facilitators, and now try to make it part of usual practice. And I wasn't quite expecting, like I was thinking, we thought of those issues from the very beginning and we accounted for that. But it's still a bigger step than I had hoped.
All right, join me in thanking Rob.